Conducting a warm handoff in primary care. Care teams play an invaluable role in identifying substance use disorder, or SUD, referring to specialty services, and supporting patients living in recovery. A standardized, team-based care workflow can be implemented in primary care settings to ensure timely and efficient delivery of care for patients living with SUD. This process may be referred to as a warm handoff. What is a warm handoff? A warm handoff is a collaborative effort between two members of a patient's healthcare team for the purpose of improving the connection and reducing the gaps in services that the patient will receive. A general warm handoff consists of one team member presenting a patient face-to-face, or via telephone if necessary, to another team member for a healthcare service. Here are two care team options for conducting warm handoffs in primary care settings. 1. Using non-clinical staff. 2. Using clinical staff. Option 1. Using non-clinical staff. In this example, the patient arrives at the medical practice. A receptionist, who is also a PDMP delegate, welcomes the patient using patient-first language. An evidence-based substance use screening tool is provided for the patient to complete in the waiting room. The delegate also conducts a patient PDMP record query. When the provider sees the patient, they review the screening and the patient PDMP record results collected by the delegate. Next steps are identified, considering the appropriateness for further testing and/or a referral for assessment. The provider determines that a referral for assessment is appropriate based on medical history, examination, and results of screening tests. The provider asks the receptionist to call the single county authority for a referral from a designated location in their practice that is private, preventing others from overhearing the conversation. The receptionist correctly performs a warm handoff by calling the single county authority and connecting the patient to necessary resources while they are still in the office. Option 1 advantages. Providing the screening tool before the visit gives the patient time to answer the questions and gives the provider an opportunity to discuss red flags with the patient. Having the delegate complete the patient PDMP record query prior to the visit is a time-saving strategy and identifies areas for additional review and inquiry. Option 2. Using clinical staff. In this example, a nurse, who is also a PDMP delegate, pulls the patient PDMP record prior to the patient visit and notices multiple opioid and benzodiazepine medications listed in the results. When the patient is in the exam room, the nurse performs a medication reconciliation and screens the patient for SUD utilizing a template available in the EHR. The patient's social history documentation is also updated based on the results of the screening test, and additional open-ended questions are asked in order to obtain the most accurate information from the patient. During the interaction, the patient shares that the pain they are experiencing has only increased since their last appointment, and no amount of medication seems to be helping. The patient requests a script for additional opioid medication. Based on the information the nurse has gathered, the nurse reports the concerns to the provider before they see the patient. During the patient encounter, the provider reviews the patient PDMP record and other gathered information with the patient. Through further examination and conversation, it is determined that a referral for assessment is appropriate. The provider asks the nurse to return to the exam room and call the single county authority with the patient, thus conducting a warm handoff. Option 2 advantages. Screening for SUD and asking questions about social history in the exam room allows for privacy and personalized discussion. Sharing concerns with the provider before the visit promotes team-based care, effective communication, and timely patient care. Next step, treatment referrals. There are several resources available across Pennsylvania. Single county authorities are county-specific offices that can help with treatment funding, assess the need for treatment or other services, and make referrals to match treatment and/or service needed. Centers for Excellence are treatment resources for patients on Medicaid with opioid use disorders. They are required to offer medication as part of a holistic approach to opioid use disorders. Additionally, there are also great online referral resources available. The Addiction Treatment Locator, Assessment and Standards Platform, or ATLAS, created by Shatterproof, PA Department of Drug and Alcohol Programs Get Help Now website, and the SAMHSA Treatment Locator. What if the patient refuses the warm handoff? A patient may not always accept an offer for specialty treatment services. When this occurs, provide the patient with a naloxone kit or information about how to obtain naloxone, information about local and online treatment resources. Evidence confirms that a warm handoff increases the likelihood that a patient will engage with specialty treatment services. Primary care may be the only healthcare setting a patient interacts with on an ongoing basis, providing an ideal environment for SUD screening and connection to treatment and recovery services. Learn more about warm handoff by accessing the Pennsylvania Department of Health's learning modules. Referral to treatment for substance use disorder related to opioid use, or It Takes a Team, providing evidence-based care to people living with opioid use disorder. Quality Insights partners with the Pennsylvania Department of Health to deliver education sessions through the evidence-based prescribing tools you can use to fight the opioid epidemic learning series. Visit our website today to schedule a presentation or view our upcoming calendar of available webinars.